My name is Amy Maxmen. I'm a freelance journalist, and I recently covered the Ebola outbreak in Sierra Leone. I knew that the key to controlling the outbreak would be containing all of the contacts that one person had. So one of my objectives was to see what that looks like on the ground. How do you actually figure out who a patient touched before they died? Now it's been over a year the outbreak's going, and I've heard that 1/3 of new cases were unknown. That means they're missing that many contacts. So it's still a massive problem. There was a lot of aid workers that were there, especially in the capital, but in the public hospitals, somehow the money was not reaching frontline workers. And that fact became sort of impossible for me to ignore. But I was almost blinded by the fact that there would be these amazing heroes just risking their lives and dying, like literally dying. Right now it's July, and there's been 11,246 Ebola deaths there. 509 of those deaths are of health workers. So it was hugely costly to them, and they weren't being paid. So at that point, I decided to shift focus and really see, who's supposed to pay them and what's going on there. Ebola, early on, when the virus first infects you, it's at a very low level. So it's hard to detect when you're first infected, and it's not causing many problems. It's very infectious just after death. So that's when the virus is at its highest level. That's why it killed you. People take care of their dead at home. So it might be a mother cleans her husband's corpse. So it became clear that was how people were passing infection. So everyone that cleaned the corpse, and then all the people they touched, they would suddenly have Ebola. And you would have small communities in various areas decide to set up their own sort of system. Neighborhoods that decided to get together and, of their own initiative, make a checkpoint. So they would actually rope off the road to their neighborhood, and they would have one person there with a thermometer, and they'd also have a big bin of chlorine. And so before you went into the village, you'd have to wash your hands in chlorine, and they'd have to take your temperature. And if you had a temperature, you couldn't come in. So whenever I wanted to walk through, I would wash my hands, and then I could go, and they'd lower the rope, and then I could go into the village. When I returned to the US, as soon as you get off the plane, you're taken into a white room. If the CDC has a list of people that were in Liberia, Guinea, or Sierra Leone, or actually all over West Africa. So you're put into a white room, and they sort of just ask you about your experience, and they classify you as high risk or low risk. I was low risk, so what they did with me is they gave me a flip phone, one of those old cell phones, and a thermometer, and I was told to monitor my temperature twice a day for 21 days, and they called me once a day and very nicely asked how I felt, if everything was normal, and what my temperature was last night and during the morning. It was a very effective system, and it gave me a really great appreciation for the power of public health and for the power of health systems when they exist. Because even though we did have a case spread here in the US, on the whole, Ebola did not break out here. What I saw in Sierra Leone was the fact that hospitals didn't have running water. So they're supposed to do proper washing of your hands. Well, what do you do if you don't have water? Those were the things I was left with, was realizing there's a very big need for infrastructure and for systems and for health systems to exist. And without that, even if you have a wonderful organization coming in with great doctors, it doesn't replace the lack of a system.